Welcome, ladies and gentlemen. It's my pleasure to welcome you to this scientific session of reproductive endocrinology. I am Dr. Shaista Kanwal, consultant endocrinologist at Hayatabad Medical Complex, Peshawar. We have an exciting lineup of esteemed speakers who will be discussing key topics in reproductive endocrinology. Before I invite the speakers, let me first invite the chairpersons who will chair this session. Our first chairperson is Dr. Fawad Ahmed Randawa, who is Associate Professor of Endocrinology at King Edward Medical University, Lahore. Sir, please come on the stage and chair the session. Our second chairperson is Dr. Nanik Ram, who is Consultant Endocrinologist at UAE. Sir, please join us on the stage. Our third chairperson is Dr. Muhammad Suhail Anjum, who is a consultant endocrinologist and diabetologist at Faisalabad. Now I'll invite our first speaker, Dr. Richard Quinton, who is a consultant endocrinologist at Newcastle upon Tyne, UK, and honorary reader in reproductive endocrinology at Imperial College, London. He will present on the induction of spermatogenesis in hypogonadal men. So let's welcome Dr. Richard Quinton.
Okay, so sorry about that. We're good to go now. I'll run through what I'm going to talk about in this session. I'm going to do some science first, I'm very sorry. Talk about the male reproductive axis, how it develops, how it works in adult. To define what we mean by hypogonadotrophic or central or secondary hypogonadism, which is the only hormonally treatable cause of male infertility. I'm going to talk about reversible hypog in relation to medication abuse or caused by us doctors, sometimes through basic misdiagnosis, and implications of having a congenital hypog versus having it acquired later in life, for instance, through pituitary disease. And to give you like a sperm induction cookbook for hypog. Just say, this is relatively simple. And so I give remote advice to people, to doctors across the world, and I have had pregnancies deep in the jungles of Central America. I have had pregnancies in Saudi Arabia. I have had pregnancies in Iraqi Kurdistan, just by coordinating with local doctors who are prescribing the treatments and monitoring. For the congenital hypog, the outcomes aren't as good as you think they might be, just by putting in the right hormones and just thinking how we might be able to improve outcomes through smarter use of the same old drugs. And mixed in with this, I'll have some clinical cases for illustration. This is the science slide, I'm very sorry, but I will walk you through it. So, these Candy neurons in the arcuate nucleus, that is what they call the GnRH pulse generator. That's where the GnRH pulse is, that's where the instructions to the GnRH neurons are generated. The GnRH neurons are a slave system. They just do what they're told. They're not a source of negative feedback, and they're not a source of the original pulse signal. That source is kisspeptin and modulated by neurokinin B. And almost all the feedback on the axis is mediated on the Candy neurons. GnRH then acts on gonadotropes. If the pulse frequency is fast, they make more LH. If the pulse frequency is slower, they make more FSH. FSH acts directly on the Sertoli cells. LH acts on the Leydig cells, which make testosterone, which in combination with FSH stimulate the Sertoli cells to navigate germ cells into becoming mature sperm. And there's very high concentration of testosterone inside the testes, about 30 to 100 times higher than in the circulation. Negative feedback, there's a partly direct effect of testosterone on the pituitary, but a lot of the effect on the hypothalamus is mediated by conversion to estradiol. Adipose tissue, too little adipose tissue, too little leptin, your axis shuts down. Relative energy deficit. Too much adipose tissue, maybe sleep apnea, adipokines, your axis tends to be blunted, although never actually shut down. So this is what it looks like if you get, this is from Franz Kalman's original paper, if you get to age 25, never having gone through puberty. And this is the ancient Greek ideal of what the human male should look like at their most virile. And this is before you had the benefit of anabolic steroids and drug abuse. This is like as virile as you could possibly get. And the anatomy is extraordinary. You'll see actually even that the left testis hangs down correctly lower than the right. He doesn't have microphallus. This was an ancient Greek cultural thing. They believed that civilized men had neat little penises and only barbarians had big, long, dangly ones. And to get from A to B, testosterone will do everything. Bar one thing, it won't give you sperm. To get sperm, you need to have paracrine micromolar concentrations of testosterone in the testes and FSH. You can't sustain sperm production through nanomolar circulating endocrine testosterone. Male and female differences, we think obviously of the ability to multitask or the inability to parallel park. But actually, one key thing is that in utero, before she is born, baby girl already has all the eggs she's ever going to have for a lifetime. But for males, they've got to go through 3 phases of testicular maturation in order to get to optimal sperm production. So this begins with external male sex differentiation from 7 weeks, mini puberty for about 32 weeks, lasting to about 5 months postnatally, and puberty, where you complete germ cell proliferation and differentiation. So in phase 1, placental HCG drives Leydig cells to secrete testosterone, and that then makes you externally male. At the same time, GnRH neurons are migrating. They're specialized olfactory sensory neurons, and they begin migrating from the nasal placode to the hypothalamus alongside fascicles of the olfactory nerve. And it's just this amazing journey. And that's one reason why we can develop Kalman syndrome. If the olfactory nerves fail to develop, these neurons do not develop. They've got no migration. They've got no scaffold to migrate along. The mini puberty, by about 32 weeks, the GnRH neurons have kind of networked up and under kisspeptin stimulation are beginning to pulse synchronously. And then that activates the entire male reproductive axis while the baby is still in utero. Further testosterone secretion, and that's the point where you get the second phase of testicular descent, which is hormone dependent. This continues until about 4 to 5 months after birth. Little boys might have higher testosterone levels than their sleep-deprived fathers at that point. And you get germ and Sertoli cell proliferation. But little boys, thankfully, do not canalize their seminiferous tubules and do not make sperm. And the reason is that the Sertoli cells don't yet express the androgen receptor, so they can't see testosterone, which you need for germ Sertoli cell differentiation. And then finally, puberty is you then have FSH and paracrine T acting to induce germ Sertoli cell maturation, seminiferous tubule formation, and sperm production. So it's quite a journey. Sertoli cells have been described as the nurse cells of the testes. Each human Sertoli cell can support 4 germ cells in adolescence and 2 in adult life, and that varies between different species. And the immature Sertoli cell tends to make anti-Müllerian hormone. But let's put some gonadotrophins into the system. Let's put some FSH in, and let's put some LH in. LH stimulates Leydig cells to make testosterone. That dual signal, testosterone, FSH, causes Sertoli cells to differentiate, at which point they tend to switch to producing inhibin B. Let's put exogenous androgens in the system, so either a false diagnosis, unnecessary testosterone, or perhaps simple androgen abuse. What do? Well, negative feedback, we shut down LH-FSH secretion, we collapse testosterone levels inside the testes, we raise testosterone levels in the circulation but we've collapsed levels inside the testes, and so we've collapsed sperm production. Thinking about the differential diagnosis of male hypog, structural causes, genetic congenital causes, functional and reversible causes. The male axis is more resistant to weight loss, but certainly I have seen really intensively exercising men who've knocked their fat mass down to like below 10%. They're all muscle. And that can be enough to completely shut their axis down. Obviously, opiates, androgens, anabolics. And then really importantly, misdiagnosis. Because you did a non-fasted venipuncture for testosterone. You did the venipuncture in the afternoon. The level of SHBG is low. So although total testosterone appears low, in fact, when you calculate the testosterone, it's normal. Or the man's covertly using anabolics all the time, or maybe cycling on and off with testosterone treatment. And there's a clinical pattern where you see information before you even see the patient. The BMI is raised, the hematocrit is high, there is a low HDL cholesterol and a low HDL-C. And you see that pattern either with metabolic syndrome or you see it with anabolic steroid abuse. And you have all this information, but you don't know who's going to walk into the room until they walk into the room and you see what the problem is. And for these men, how to restore fertility, stop their testosterone, if someone prescribed it to them. So congenital hypog, which would be my interest, it's failure to initiate or to complete puberty. About a third initiate puberty but doesn't progress. Low testosterone with low or low normal LH and FSH. Otherwise, there's no other pituitary dysfunction, normal MRI. Any of excluded secondary causes such as hemochromatosis, for instance, or pituitary tumors. Congenital defect to generate secretion or action. There's a very high prevalence of cryptorchidism and often a history of neonatal micropenis. That's due to absent mini puberty. New genes keep getting discovered every year. Honestly, I've lost count. But we still only understand the genetics of around about half the cases. In practice, the risk of transmission the disease through fertility treatment seems to be around 5 to 10%. And there are also important non-reproductive phenotypes in about 60% of cases. Most commonly anosmia, which is Kalman syndrome, but also deafness, cleft lip, cleft palate, digital anomalies, dental anomalies, synkinesis, renogenesis. So sperm induction in hypog, 101, first lesson. What do we need to know? Who is sitting in front of you? Did his factory, was it already built and we just need to turn the power back on again? And that can either be by giving gonadotrophin therapy or simply stopping the exogenous androgens that were keeping it suppressed. Or do we first need to build his factory from ground zero, which is CHH? And the approaches are different according to whether it's power back on or build the factory from the ground up. So what are the drugs we've got? We can't use LH because the half-life is far too short. HCG acts on the same receptor, has a longer tail on it, so it's got a much longer half-life. Various forms of it. The cheapest is the better. Similar to testosterone by Leydig cells, and that paracrine testosterone works in the testes, and the endocrine testosterone maintains secondary sex characteristics. And so sertoli and germ cell differentiation, and also inhibition of proliferation. And then we have FSH, also known as, it can be human menopausal gonadotrophin, was historically extracted from menopausal women's urine. HCG was historically extracted from pregnant women's urine, but now it's generally recombinant. And that induces sertoli and germ cell proliferation. And when you combine that with paracrine testosterone under HCG stimulation, that gives you tubule formation, testes growth, and sperm production. And just to say that the combined gonadotrophin regimens for sperm induction in adult males are very similar to those that specialist pediatricians use to induce puberty, and very similar to regimens that you can use for medical orchidopexy. So how likely is gonadotropin sperm induction to succeed in hypog-hypog? Well, again, it depends. Are you turning the power back on again, or do you have to build the factory from ground zero? So I'll start with the turn the power back on again one. He's 33 with acromegaly, transferred on surgery 3 years ago. His wasn't quite cured, but he's now well controlled on cabergoline, partial hypopit, well replaced on thyroxine and testosterone gel. Testes are 12 mil. He has 2 children by his former wife. New wife, no pregnancies, mid-20s, regular cycles with premenstrual symptoms. The couple are now wanting fertility. So we think of what are the positives and what might be the obstacles. Well, the positives are, so men with adult onset hypog-hypog on testosterone may still retain fertility. In his case, not. In his case, he was asospermic. Also, you may well be able to restore fertility with HCG alone, which simply replaces the testosterone. You make your own testosterone. And HCG is usually cheaper than FSH. Doses vary hugely. Highest dose ever used is 10,000 units a week, lowest dose 1,000 units a week, and it's generally split into 2 or 3 divided doses. And really you're adjusting the dose every 6 to 12 weeks, aiming to keep levels of hemoglobin, hematocrit, testosterone, and estradiol normal. So it's similar in principle to testosterone replacement. Normal hematocrit, normal testosterone level, but in addition, you also want to maintain a normal estradiol level, because if you drive the Leydig cells too hard with HCG, or if they've been driven too hard with LH, saying Klinefelters, the ratio of estrogen to testosterone rises, and therefore they're at risk of gynecomastia. And then, of course, if you fail to achieve sperm, or you achieve some but not enough, then you can always add in FSH or HMG later on to optimize sperm production. But he has testes that are reasonable size. He's had 2 children in the past. His wife sounds like she's young and fertile. All these are favorable things. So let's go. Time 0, he's off testosterone. He hasn't started HCG yet. Testes 12 mil. Total testosterone level very low, 1.2 nanomole per liter. So that's what, maybe 25 of your American units. There is he's got some endogenous FSH floating around there. No sperm. We start HCG, 2,500 units twice weekly. At 3 months, testes have grown a bit. Testosterone level is now fully normal. Estradiol level has begun to climb, and I should have reacted to that, but I didn't. 7 months on the same dose of HCG. He's got sperm, 5 billion, outstanding. But you can see that his total testosterone free and estradiol have overshot, and I put him at risk of gynecomastia because I should have reduced the HCG dose back at 3 months, but luckily he got away with that. And then 11 months, at this time I've reduced the HCG dose, he's got 30 million sperm. At 14 months, actually he's out of HCG, his GPs refused to prescribe it, but his sperm count's 51 million, which is brilliant. And his wife's pregnant, which is marvelous. So he previously went through normal mini-puberty and puberty. So to get the factory working again, we just needed to turn the power back on again. But for congenital hypog, where the testes may be as small as 1 or 2 mil, we first need to build the factory. So here we have a normal adult male, on the testes 25 mil, testosterone level, what, about 500 of your units, nice LH pulses, and mature testes with seminiferous tubules and ongoing sperm production. And this is the severe end of congenital hypog. 2 more testes, testosterone 0, no LH pulses, and really immature testes. So what happens if you give these men HCG alone, even if you're prepared to carry on going for like up to 5 years? Well, not very much. So after 1 year, 7 are still asospermic, 1's got a few sperm. At 2 years, 5 asospermic, 3 have a few sperm. Up to 5 years treatment, 3 are still azoospermic, 4 have got a few sperm, 1's got a sperm count that's probably compatible with fertility. And so even without cryptorchidism, which is very common in hypog men congenitally, and even with prolonged HCG treatment, monotherapy with HCG, which was really good in the acromegalic man, is futile in these men. It's just not worth doing. You're just wasting time. Remember, the partner's now 5 years older too with reduced fertility. Also, it's very hard to normalize serum testosterone on HCG monotherapy in men with congenital hypog. So they can really struggle with sexual function and with well-being. And sometimes they ask, well, can I have testosterone put back in again just to assist with that? And also, on the theoretical grounds, if you have a relatively small pool of immature Sertoli cells, and it'll be even smaller if you have a history of cryptorchidism, the last thing you want to do is put in the endocrine signal to differentiate before they've had a chance to proliferate. And really, these hypoendocrine congenitals, they need, with the small testes, they need FSH at least at the same time as HCG, and maybe even before then. Some predicting factors. So the final testicular volume you achieve on sperm induction correlates quite well with fertility. And so the smaller your testes at baseline, the smaller it's going to be after treatment. So the less likely you are to succeed. Smaller testes, less Sertoli cells. The lower your inhibin B level at baseline, the smaller your testes at the end of treatment, the less likely treatment is likely to succeed. So lower inhibin B, less Sertoli cells. If there's a history of cryptorchidism, particularly if it's bilateral, the testes at the end of treatment are going to be smaller, the treatment's less likely to succeed, less Sertoli cells. So in terms of, testicular size is a surrogate outcome. Let's look, well, I guess you could say that sperm appearance is also a surrogate outcome because the real outcome is take-home baby. Anyhow, one step further down the line. So this is 3 to 7 injections a week, duration 1 to 3 years. What percentage of patients get sperm at the end of it? Well, if you're looking at the 1/3 of congenital hypogs who presented with partial puberty, testes larger than 4 mil, 80% of them get sperm. 20% still get none at all. If you look at the 2/3 of hypog males who presented with absolute puberty, no LH pulses, so they have smaller testes, less than 4 mil presentation, only half of them get any sperm at all. And what about the ones who are bilaterally cryptorchid? It's Disasterville. So we're putting the hormones back in again. We're not getting the results we would have hoped. And that was just any sperm. But what about the sperm counts? What is the best sperm counts achieved? In the right-hand column, these are 19 males who presented with partial puberty, so larger testes, and the median sperm count is 30 million. All of them developed some sperm. The left-hand column, 32 males who presented with absent puberty, smaller testes, of whom 9 never got any sperm at all. And the median sperm count was only about 8 million. So thinking about how you predict success for sperm induction in hypog, there are pre-treatment predictors, things you know before you even started. And there are other things that give you more information during treatment, so in-course predictors. So pre-treatment predictors, partners young and fertile, great. But often these men have had to navigate a complex web of referrals before they finally get to see a doctor who knows what the hell they're talking about, during which time their partner's getting older and older and older and older. If you have adult onset hypog, for instance, due to a pituitary tumor, so you've already had mini-puberty and puberty, that's good because you built the factory, it just went to sleep afterwards. If you have congenital hypog, but you're one of the 1/3 of ones with partial puberty, larger testes, more Sertoli cells. That's quite a good thing. And not being cryptorchid is really good for two reasons. First of all, being cryptorchid means that you may not be subject to thermal or surgical trauma, and potentially, because you weren't cryptorchid in the first place, that may be signposted a relatively mild neuroendocrine defect, more Sertoli cells. Having a higher basal inhibin B level, more Sertoli cells, and not harboring this particular mutation, which is characteristic of X-linked Kalman syndrome. What about the things you pick up during treatment, during the journey, that suggest that things are going well? So the testes are increasing in size on treatment, and the inhibin B is rising. You've given them a decent dose of FSH, you're actually getting a serum FSH level greater than 4 units per litre. Units of FSH will vary between 150 and 300 units 3 times a week. Give whatever you need to give to achieve a decent FSH level. Achieve normal levels of hemoglobin, estradiol, testosterone, and also if you had a very low test at the beginning, you didn't waste time with the HCG only phase. If you were bilaterally cryptorchid to begin with, there's some data to suggest that if you give them 2 to 3 months of FSH first, whilst carrying on with testosterone, and then you replace testosterone with HCG, that may help augment the limited basal Sertoli cell mass. So I've got 3 more clinical cases. This one's quite quick. Comes into A&E with headaches. You see the enlarged pituitary fossa. There we go. Big pituitary tumor, prolactinoma. Endocrinologist says, we'll treat with cabergoline, tumor will shrink, hypopit may recover. Meanwhile, we'll give hydrocortisone, thyroxine, maybe testosterone. The specialist says, come on, his wife's 38 years old. She wants kids. We haven't got months or years for this. He needs FSH and HCG now. There's no point in him having a great sperm count when his wife's 45 years old. This man has Kalman syndrome. There's no history of cryptorchidism. He was azoospermic on testosterone gel, tested 3 mil, married, young wife, regular menses, wants fertility. He was started on FSH, but kept on testosterone gel. After 2 years, he's still azoospermic, but his testes, interestingly, have doubled in volume. Couple were referred to a fertility center for donor sperm. Luckily, he was then redirected to me. So we put in HCG in addition to his FSH. Here we go. At 1 month, we can see we got total overshoot. We got testosterone, estradiol way over. And so we have to backpedal with the HCG dose. And actually, you can see we're not giving you enough FSH. He's only got 2.6 units a litre. Despite lowering the HCG dose, we're still way over on testosterone estradiol. Luckily, he doesn't get gynecomastia. Again, we backpedal on the HCG dose. But his inhibin B is coming up nicely. 7 months, lower dose. We've got to lower it even further. Testes have increased nicely, 20 mil. 10 months, everything's okay. Testes now 50 mil. He's got a low dose of HCG. He's on the right dose at last of FSH, getting him a decent serum level. Inhibin B is brilliant. Everything's perfect, except he's got no sperm. And so maybe it's the fact that he had so many years of FSH on his own that helped. But actually, I hadn't examined him properly. He actually had obstructive azoospermia with bilateral vas deferencegenesis, negative cystic fibrosis. And so he needed testicular aspiration and Enixene as a child. Case 4, presented with absent puberty, aged 19 years, as is typical in these individuals. Pubertal induction regimen, libido, 1 gram every 4 months. He was right cryptorchid. He was ready for orchidopexy. And his urologist said to me, Richard, make life easier for me, lengthen his spermatic cord, make his testes bigger, make the operation easier for me. So we started on FSH, no further libido. After 3 months, we added in HCG. 6 months later, both testes in the scrotum, operation cancelled. And we've had 2 more cases since then, and that's published in Clinical Endocrinology. So how are we going to improve sperm outcome in congenital hypohypog? We need to hammer down on the neonatologists. Boys born with bilateral cryptorchidism or unilateral with micropenis, they need to be identified. Simple blood test. LH, FSH, testosterone. You can diagnose congenital hypog in a 3 to 4 month old boy. Treat them with FSH and HCG, bring their testes down. You can avoid orchidopexy surgery in 80% of cases. And you made a diagnosis then. Made a diagnosis. So then you can set them up to pubertal induction age 12 years, instead of waiting until they're 19. Send men to specialists whilst their partners are still young. HCG monotherapy is pointless in men with congenital hypog and smaller testes. They need combined therapy. Adjust your FSH dose to achieve a decent serum level. Adjust your HCG dose. And don't give up until at least 2 years have gone, and think about sperm banking afterwards. And then if they have children, check them for absent mini-puberty. So many thanks for this. I've got some references here if you're interested. They're all on my ResearchGate site, free to download, and I'm open to questions.
Thank you, sir, for such a wonderful talk. We'll take questions at the end of the session.